All right, so we are going to start talking about autoimmune diseases of the neurological system. As previously discussed, when we're talking about our body's immune response, the first step is that inflammatory process that happens. So an autoimmune disease is essentially when that inflammatory process doesn't stop after the offending agent has been removed or has been corrected, and it eventually starts to cause damage to our body's normal healthy cells over a long period of time. And so these diseases that we're going to look at are a result of chronic inflammation and an immune response in the brain. The first autoimmune neurological disease that we're going to talk about is multiple sclerosis. Multiple sclerosis is an immune-mediated progressive demyelinating disease of the CNS. And so essentially, and I'll show you this in the next picture, our nerves are surrounded by what's called a myelin sheath. And this disease, as a result of that immune-related process, those myelin sheaths are being destroyed. Clinical manifestations vary and can present in different ways. The cause of MS is not completely known. They are thought to have some genetic risk factors and other risk factors, but nothing's really been able to be pinpointed as the cause. Frequently, this disease has a relapsing and remitting occurrence, and so you have exacerbations and recurrence, and then you'll have periods of recovery. And even with that relapse and remitting type of course, eventually your brain begins to suffer some cognitive defects as a result of all of the damage. Symptoms could include fatigue, weakness, numbness, difficulty in coordination, loss of balance, pain, and some visual disturbances. Medical management for this type of disease is going to be potentially the management of muscle spasms, helping the patient to deal with fatigue, ataxia, and bowel and bladder control can all be affected by this disease. And so this is just a picture of what I just tried to describe to you. Here we have those nerves, and you can see the myelin that surrounds that in these pictures. So A just shows you a normal nerve cell, an axon with that myelin, and then C and D kind of show you the disintegration of the myelin over a period of time. And here is just kind of chart that shows you that 4 different types of courses of MS, that relapsing recurrence, as we can see, we have clearly acute attacks, but then we have clear full recovery and lack of disease progression. In that primary progressive type of disease, we have continual progressive of the disease. In secondary progression, you can see we start with that relapsing, remitting, but eventually we move to a progressive type of course. So when talking about the nursing process for patients with MS, signs and symptoms of MS are going to vary from patient to patient depending on what part of their brain is being affected. The most common symptoms usually, again, are depression, fatigue, weakness, numbness, difficulty in coordination, loss of balance, spasticity, and pain. So that word ataxia essentially means impaired coordination of movements. They have trouble with movements, and then spasticity usually is a result of muscle hypertonicity. And it occurs in about 90% of the patients with MS. Pain is another common symptom of MS. A patient who deals with chronic pain also is more likely to suffer from social disconnect, depression, and So that's why when we think about patients with MS, we really have to include psychosocial assessment and psychosocial care into their care plan. And then also patient and family coping. So a lot of times, especially in a progressive course, family members become caregivers. Family members who are caregivers run the risk of burnout. They run the risk of resentment. And so it's really important for us as nurses to make sure that we are including the patient and the entire family in our plans of care. When we look at some of our official nursing diagnoses related to multiple sclerosis, we're looking at impaired physical mobility, risk for injury as a result of that ataxia. A lot of times, the nerves that control bowel and bladder function can be affected, as well as nerves that contribute to verbal communication. They may have a disturbed thought process, some cognitive deficits. And then again, looking at that psychosocial aspect, they could be some ineffective coping, impaired home maintenance, and potential sexual dysfunction as well as a result of some of the damage to those nerves. So our major goals for this inpatient, we're going to try to promote as much physical mobility as possible. We want them to be safe. We want to reduce the risks of falls, reduce the risk of injury, achievement of bowel and bladder continence, promotion of speech and swallowing mechanisms, improvement in cognitive function, helping them to develop those coping strategies, improved home maintenance, and adaptation to sexual function and how that affects them in life. So when we're looking at interventions and how we care for the patient, it's always best to use a collaborative approach. So we want a multidisciplinary care team. Usually is going to be made up of doctors that specialize in this type of disorder, primary health care providers, case managers, social workers, the patient, and the family. It may be necessary for you to try to coordinate and advocate for referrals to different healthcare services for your patients. Again, social services can be a big one in helping them with any type of social issues that may arise, whether that be financial, whether that be transportation, speech therapy to help with their verbal communication and to help with their swallowing, physical therapy to try to improve physical mobility, counseling services if needed, home care services, and so on. So we need to look at this from a multidisciplinary care setting. We want to try to both promote activity and rest at the same time. So we want to improve that physical mobility. So you're looking at gait training, rehabilitation, but also we need to establish a balanced program that includes rest and exercise so that our patient isn't getting fatigued. Relaxation, so maybe teaching some guided imagery or maybe even utilizing medical massage and helping PT, so helping with walking, muscle stretching exercises, but avoiding very strenuous activity and anything that could cause extreme fatigue. When we're looking at interventions for bowel and bladder control, so perhaps they've been prescribed a medication that can help with that. So we want to make sure that they are familiar with the medication, they understand the instructions and how to administer. Creating a voiding schedule can help, especially when we're trying to avoid urine retention. Teaching the signs and symptoms of what urine retention may feel like. If necessary, they may need intermittent catheterization. Being able to identify the signs and symptoms of a urinary tract infection is going to be important. Adequate fluid and fiber. So we want to try to prevent constipation. Reinforcing those swallowing instructions. So we want them to be able to participate in exercises recommended by speech therapists to help keep that swallowing function, maintain adequate nutritional intake without aspiration. So we are trying to prevent any type of aspiration pneumonia developing in these patients. So we want them to work with speech therapists to develop some exercises and practices that can help keep their swallow function going. Memory aids can be helpful with cognitive function. A structured environment, a daily schedule, all of those can help to keep their cognitive function and promote their self-confidence, because as they're able to participate in their daily care and participate in their lifestyle, it will help to help them deal with those social aspects of having a chronic disease. So further interventions, so we want to try to minimize stress for this patient in any way we can. Again, that's why that multidisciplinary care team can be so important. We want to try to adhere to a plan for home maintenance management. So whether that be installing an air conditioner to avoid excessive heat, or making sure that they have a good furnace, or they understand the importance of not being exposed to extreme cold, using assistive devices or modifications for home care management as recommended by PT, OT, but our goal is to promote as much independence in their activities of daily living as possible, and then also providing that support for coping with the disease process. So maybe they need to speak to a therapist, or maybe they need a consult for psychology or psychiatry, depending on how bad the depression may be affecting them. So making sure that we're taking advantage of all of the resources available to our patients, because there is no true treatment for this disease. We can only support the patient in what they're going through. So it's important to remember, when we have these types of neurological degenerative diseases, movement can be a major dysfunction for these patients. So helping them to be able to move, to be mobile, to care for themselves is always going to be some of our highest priorities. All right, moving on, we're going to talk about myasthenia gravis. Myasthenia gravis is another autoimmune disorder that affects some of our nervous system. It specifically affects that myoneural junction, which I'll show you a picture of on the next slide. But what's happening is antibodies are directed at acetylcholine at the myoneural junction, which impairs transmission of impulses. So nerves communicate through impulses from one nerve to another. So what's happening in this disease is that those impulses are being impaired as a result of antibodies that are created. This disease primarily, although it is affecting our nervous system, it's usually characterized by varying degrees of weakness of the voluntary muscles. So initial symptoms involve usually ocular muscles, so patient may complain of diplopia or ptosis, and then they may also develop weakness of facial muscles, potentially moving to swallowing, voice impairment, and then perhaps a progressive generalized weakness that affects all of their extremities, our intercostal muscles, really then affecting our respiratory system as well. And this is just that picture of the muscle end plate, and it kind of gives you an idea of how it's supposed to work in picture A, and then what is happening as a result of those antibodies, and that's picture B. So medical management of myasthenia gravis, which technically should only be a temporary type of condition, is based on improving function while reducing and removing those circulating antibodies against acetylcholine. So pharmacological therapy can really help with this. Anticholinesterase medications, so that pyridostigmine bromide, I know that's a very large word, is basically it provides some symptomatic relief by inhibiting the breakdown of acetylcholine and increasing the concentration of available acetylcholine at that neuromuscular junction. So that helps to improve those impulses. I don't expect that you know the pathophysiology of myasthenia gravis. Rather, I expect that you really focus on what nursing treatment and care plans look like for this patient. However, it's important for you to have a baseline knowledge of what exactly is happening. So we have those medications. Also, IVIG can be given to help reduce some of those, to attempt to reduce some of those antibodies. And then also there's something that's called therapeutic plasma exchange. It's oftentimes referred to as plasmapheresis. Essentially what's happening is the patient's own plasma and plasma components are removed, and then in a machine, the blood cells and antibody containing plasma are separated, and then after which the cells and a plasma substitute are reinfused. So we're looking at a temporary reduction in the level of circulating antibodies as a result of this plasmapheresis. And then a thymectomy, it's surgical removal of the thymus gland, can produce antigen-specific immunosuppression, and result in clinical improvement. So those are just a few of the things medically that can be done to help assist a patient with myasthenia gravis. So when we're looking at two potential complications of myasthenia gravis, the first one is a myasthenic crisis. And basically that's a result of disease exacerbation or some sort of precipitating event. Mostly it can be brought on by a respiratory infection. So the flu, something like the flu, can oftentimes bring upon a myasthenic crisis. And I know I said in the previous slide that the disease is temporary, but it's a chronic disease that should have temporary types of exacerbation that should be treated. But these myasthenic crises often result in severe generalized muscle weakness, and that can really affect a patient's airway. And so as those respiratory muscles are weakened and they do not support inhalation, patient could have an inadequate cough as a result of it, an impaired gag reflex, and that results in poor airway clearance. So potentially this patient can move to respiratory failure as a result of a myasthenic crisis. They may need intubated and put on mechanical ventilation for a time. So it's important to be aware of your patient's respiratory status if they are dealing with a myasthenic crisis. Because like I said, they could get pretty sick pretty quickly and may need some mechanical ventilation. On the flip side of that, a cholinergic crisis can be caused by over-medication with those cholinesterase inhibitors. So that pyridostigmine bromine is a type of medicine that, if given too much, it could lead to a cholinergic crisis. So again, your patient could develop severe muscle weakness, as well as and if that affects the respiratory system, and could potentially move to respiratory compromise and failure. So at this point, with a patient that's experiencing any type of crisis with myasthenia gravis, we need to be worried and concerned with their respiratory system, their respiratory function. In addition to, if they're struggling with a cholinergic crisis, we want to make sure that we're stopping those medications, those cholinesterase inhibitor medications, for the time being. So management of a myasthenic crisis, we want to make sure that before this happens, a patient is educated on the potential signs and symptoms of a myasthenic crisis or a cholinergic crisis. If they are suffering from one of these, we want to make sure, again, that we're keeping a very close eye on their respiratory status, ensuring adequate ventilation. They may be intubated, they may be mechanically ventilated. If that is the case, then we're looking at assessment and supportive measures. So we're going to be monitoring them probably in an ICU area. They're probably going to be using labs like blood gases, electrolytes. If a patient can't swallow, potentially they may be utilizing an NG feeding, because remember, those swallow muscles are affected as well. We don't want them aspirating. But at the same time, we're trying to do as much as we can to avoid sedatives or tranquilizers, because we do not want to depress them any further than they already are depressed. So when we're talking about Guillain-Barré, or I always want to say Guillain-Barré because that's what it looks like to me, we're talking about another autoimmune disorder that affects that nerve myelin, most likely those peripheral nerve myelins. Basically, it's rapid demyelination that can produce respiratory failure, autonomic nervous system dysfunction, and cardiovascular instability. This most often follows a viral infection. So again, this could be something that happens as a complication of the flu. Manifestations are going to be variable from each patient, and they could include weakness, so muscle weakness, paralysis that is usually only temporary, paresthesia, so that tingling sensation of numbness and tingling, or pins and needles, pain, diminished or absent reflexes, starting usually in the lower extremities and progressing upwards. So bulbar weakness, essentially bulbar weakness kind of talks about the nerves that originate from the bulb-like portion of the brainstem. Sorry. When you think bulbar weakness, you should think about talking, chewing, swallowing, holding head up. All of those types of functions can be impacted by bulbar weakness. Cranial nerve symptoms, tachycardia, bradycardia, hypertension, or hypotension. So we see this disease process has the ability to really mess with cardiovascular instability, as well as potentially affecting a patient's respiratory system as well. So when we're looking at medical management, this type of situation is often thought of as a medical emergency. Usually this patient will be in intensive care and need some sort of continuous monitoring and potential respiratory support, because cardiovascular and respiratory system can be affected by this. So that plasmapheresis that we talked about before, the removing the patient's plasma and plasma components and separating them out and infusing a substitute could be possible, as well as that use of IVIG, again, to try to reduce those circulating antibodies. Most patients will recover completely from this type of disease. It's just a matter of supporting them as they're going through it. Assessment for a patient. So this is, again, going to be continuous monitoring, ongoing assessment. Emphasis is going to be on early detection of life-threatening complications. So monitoring my patient's respiratory status, monitoring their cardiac rhythms. They'll probably need telemetry, potentially watching for a DVT, because they could be constrained to their bed as a result of paralysis. And then assessing their vital signs frequently, and monitoring of those ECGs, like I said. And patient and family coping, because this is scary. Like, it is a scary thing, and it happens very quickly. One day you are fine, or maybe dealing with the flu, and a few days later, now you're paralyzed. So it comes on very quickly, and it can be very scary for patients and family coping. So reassuring them is going to be part of your care plan as well. So looking at some of our nursing diagnoses related to Guillain-Barré syndrome, ineffective breathing pattern as a result of the muscle weakness, impaired gas exchange, impaired physical mobility, imbalanced nutrition because they aren't able to take in as much nutrition as their body requires because they're not able to swallow, impaired verbal communication as a result potentially of that cranial nerve dysfunction, and then fear and anxiety, again, related to loss of control of their own body, related to all of a sudden this paralysis that they're experiencing, can really affect a patient mentally. So we want to try to avoid any type of complications, but some of the ones that can occur, again, respiratory failure, they may need intubated, they may need to be on a ventilator, autonomic dysfunction, so they may be experiencing, so as a result of autonomic dysfunction, they may experience non-voluntary, they may lose the ability to regulate some of their body functions that are non-voluntary. So think of heart rate, blood pressure, sweating, all of those things our body regulates for us. As a result of this syndrome, it may lose the ability to regulate such things. So that's why vital signs, continuous monitoring is so important with these patients. DVT and pulmonary embolism, we want to make sure that we're turning these patients every 2 hours, that if necessary, they have SCDs on to try to prevent DVTs because they're immobile, watching for urinary retention as a result of that neuromuscular dysfunction as well. So our major goals when we're creating a care plan for this patient is we want to improve respiratory function. So some of the ways that we can improve respiratory function for our patient, we're looking at incentive spirometry or maybe that chest physiotherapy, making sure that we're keeping a close eye on their vital signs, and then perhaps progressing to mechanical ventilation if possible, or if needed, So increasing mobility, if our patient has paralyzed extremities, we want to make sure that they're supported in functional positions, that we're doing passive range of motion exercises. Again, we're watching and trying to prevent a DVT or PE formation, making sure that we're using padding over any type of bony prominences and helping to change their positions to reduce the risk of pressure ulcers. Improving nutritional status. So if they are unable to swallow as a result of that paralysis, they may need IV fluids or they may need TPN as a result of that. They may have insufficient movement within their bowels. So if that's the case, we don't want to give them NG feeds if their bowels aren't functioning. So they may need TPN temporarily. We want to try to improve their communication because, again, of that bulbar paralysis, the patient may not be able to talk, laugh, cry. So we want to establish some sort of communication with this patient. It could be in the form of pictures or eye blinks. But again, bringing in that speech therapist can be helpful as well because remember, cognitively, your patient is very aware. They're just not able to communicate. So we always have to keep that in mind. And then it's always important that we communicate back with them. So even if they're unable to speak, we want to make sure that they know what we're doing before we do it. So if we're getting ready to assess them, take their vitals, take their temperature, whatever it is, making sure that we're telling our patient that we are what we're doing when we're doing it, and then trying to decrease fear and anxiety amongst the patient and the patient's family is going to be important as well. And this slide just kind of reinforces what I said in the last slide about specific interventions that we can do to try to remove some of those complications. So enhanced physical mobility, prevention of DVT, administer that IV fluid or TPN as prescribed, assessing swallowing, gag reflex, because ultimately we want to prevent aspiration because this patient is already potentially facing respiratory failure. So we would hate for them to develop an aspiration pneumonia as a result of it as well. And then further interventions, so developing that plan for communication and trying to decrease that fear and anxiety. A lot of that can be eliminated by providing information and support up front. So making sure that the patient is educated, the family, maintaining a positive atmosphere, relaxation techniques, perhaps some diversional activities can all be helpful. And then potentially asking or advocating for a referral to either a support group or maybe a counselor, psychologist is potentially on staff at the hospital that could be utilized as well to help this patient.